Good evening, everybody. Thank you for joining us tonight. I think we're going to hop right in. I think people are going to keep trickling in, and that's totally okay. But I'm Danny Sikowski. I'm a fourth year medical student in the Chicagoland area. I'm one of the co-chairs for Doctors for America's Gun Violence Prevention Subcommittee.
Welcome and hello, everyone. My name is Colin Wilson. I am also the other co-chair on Doctors for America Subcommittee on Gun Violence Prevention. I'm a 4/5 year medical student in the Cleveland, Ohio area, and just want to thank everyone for joining tonight for tonight's great discussion.
Before we get started, I just want to take a quick minute to invite everybody here to officially join Doctors for America. Being a DFA member today means taking the important and simple step of selecting a membership level and paying your annual membership dues to support our organizational sustainability, as well as incredible programs like this one, like our Advocacy Grand Round series. There are 4 different membership levels to choose from, and a link will be put in the chat on where you can join.
And just some ground rules before we get started. So this discussion tonight, our advocacy and rounds, will be recorded. The recording and all materials will be available afterwards. And couple other ground rules. First, there's no such thing as a stupid question, so feel free to ask, and there's no shame or you won't be ridiculed for anything. We really want to hear what your questions are and have them answered. And then speaking of questions, please remember to use the Q&A feature. We will address your questions as time permits, and also look out for comments in the chat. So we might answer them in the chat as well. DFA staff will be sharing helpful links during the session too, so keep an eye on the chat for that as well. This evening, we are excited to have 4 incredible panelists share their experiences and discuss with us how to further advocate for our patients and communities impacted by firearm violence. Additionally, we hope this discussion sparks evaluations into how we can better communicate and care for survivors and their families, both immediately and dealing with the long-term effects of gun violence.
Now, on to our speakers. We are thrilled to welcome Alicia Schemmel, Dr. Anthony Douglas, Maisha Watkins, and Gregory Jackson. Just briefly introducing them, Alicia Schemmel is an Everytown Senior Survivor Fellow, One AIM Survivors Council Board member, and Live Free Illinois Clearance Rate Strategy Team Lead. Dr. Anthony Douglas is a general surgery resident physician at the University of Chicago.
Maisha Watkins is the executive director of Cleveland Peacemakers Alliance. And last but certainly not least, Gregory Jackson. He is the president of the Rocket Foundation, advisor to Community Justice Action Fund, and a strategic consultant on gun violence prevention. To kick off our questions for the panelists, we'd like to invite each panelist to briefly share their backgrounds and experiences.
Great, thank you. Thank you guys so much for having me, and thank you for the great introduction. My name is Alicia Schemmel. I have been working in gun violence prevention for a little over 25 years now, since my dad was shot and killed in a mob hit. And the past 7 years have been focused on unsolved homicides. Currently, we only arrest someone in about 18.6% of homicide cases on average across the country. So most recently here in Illinois, a small group, just 5 of us, wrote and passed a bill that directly addresses the issue of unsolved homicides. It's called the Homicide Data Transparency Act, HB 1710. This bill, it mandates that law enforcement reports out their homicide clearance rate data to a governing body who will then make this data publicly available, with the goal being that when the general public knows that we have such a low homicide arrest rate, that it'll raise some awareness around the issue and hopefully bring more perpetrators to justice. And without clear and concise data, we can't create evidence-based solutions to ending gun violence. So I thank you so much for having me tonight.
I'm happy to go next. My name is Anthony Douglas. I'm a surgical resident at the University of Chicago, finishing my training focused on trauma and acute care surgery. The last 2 years, I've been focused on building skills and the tool set to be an advocate outside of the hospital, mainly fighting for affordable prescription drugs as well as violence prevention. Last year, we introduced a bill called the Responsibility in Firearms Legislation Act, which aims to hold firearm manufacturers accountable for the outcomes of their products in Illinois communities. In the process, providing funding for CVI and victims of firearm injury. And I'm proud that DFA has been a great supporter of that legislation and happy to be here. So thank you for this opportunity.
I can go. My apologies that I'm off camera. Greg and I were in DC at the federal courthouse to support the CDICI and getting their money back from the federal government. My name is Maisha Watkins, Executive Director of an organization called Cleveland Peacemakers. It's a community violence intervention organization. We work in both level 1 trauma hospitals in the city of Cleveland, which is Metro Health, the University Health Hospital. On June 24th of this year marks 1 year since my cousin was shot and killed in a city that I do work in, and came to one of the trauma hospitals where my team respond. And instead of responding for the community, they were responding for me, the executive director of the organization. I would say it is different on this side as a survivor, but I am committed to the word. I'm also a graduate of the Community Violence Intervention Leadership Academy through University of Chicago. Cleveland just declared gun violence a public health crisis, and our county just announced a new Office of Violence Prevention.
All right, I'm bringing up the caboose. Greg Jackson here. Come to you all as a survivor first. Unfortunately, I was shot in April of 2013. The bullet that hit me hit 2 arteries and nearly cost me my life. But thankfully, I survived and have spent the last 12 years advocating and fighting for policy change, as well as working directly at city level, state level, and then most recently serving in the White House as the deputy director for the first ever White House Office of Gun Violence Prevention. And just really proud of that phase of my journey where we were able to help oversee an effort to reduce gun violence by 31% in 3 years, and move forward 54 executive actions, the first law in 30 years, and $42 billion of resources. And it's probably no surprise to anyone, all of that is under siege now, but that's what brought me here. And I do apologize for being outside. We literally just left the hearing, Maisha did too, where we literally just fought against the Trump administration and the Department of Justice because of over their unconstitutional cuts to DOJ funding to CVI programs and strategies. So we're both mobile, but for good reason.
Yeah, well, thank you, Greg and Maisha, especially coming from hearing that and being with us tonight. Thank you all for sharing. We're going to move now into some further discussion. As a reminder to our attendees, please feel free to use the Q&A function or the chat within Zoom. We do hope to have some time at the end for some of your questions, and then also trying to address some of them in the chat as they come in. So to kick off, we kind of heard from your guys' introductions, some of the things you've been doing. What can be done kind of differently at the community, state, federal level for victims and families impacted by firearm violence?
I think that first of all, when you're in the ER and somebody's shot, it's not like you woke up that morning thinking that that was going to happen to you. I mean, I didn't wake up on August 14th of 1999 thinking like today's the day that my dad's going to be murdered. So when that does happen and you're there, to say you're like in a complete state of shock is a total understatement. And I think we need more resources at the hospital in the ER to help guide people for when that happens for the days and months afterwards. There's a lot of hospital-based violence intervention programs that serve as critical intervention points. And embedding social workers, trauma counselors, and victim advocates in ERs can really guide families through next immediate steps and connect them to resources and begin that trauma and care right away. That's just my 2 cents.
Yeah, at the community level, I think, certainly supporting your hospital-based violence prevention programs and community violence intervention programs is very important, especially as physicians. A quick story, our trauma center at the University of Chicago was reopened in 2018 after 25 years of the South Side going without a trauma center. And that trauma center, the founder, Dr. Selwyn Rogers, refused to open that trauma center unless it had a hospital-based violence prevention program. And it just just sheds light on how important these type of programs are to help people recover after injury. And so, whether you're whatever stage of training you're at, or whether you're done with training, making sure that your hospital is valuing not only just in words, but in dollar signs, the work of those people who are doing that work at the community level. is important. I would say at the state and a little bit the community level, getting involved in your local grassroots organizations. You know, physicians certainly bring a needed expertise and can leverage their credibility to help the grassroots organizations make an impact, whether it's at the policy level, fundraising, rallying, all the above. And so I would say Greg is probably a better person to talk about at the federal level, but I would say those are the two main things at the community and state level.
I think I'll jump in to add too. I think that the struggle is that hospitals don't understand how complementary this work is to one another. That in order, I know the life is saved in the hospital, but in order to allow for a sense of safety and normalcy, the community needs to be involved for the wraparound services. Too often, patients or community members are treated like suspects instead of patients. So the biases there make it hard. And then with this being non-traditional work, oftentimes the credentials that most hospital staff have, staff that I lead, organizations that I work with, we don't have that type of credentials all the time, especially the people who are proximate to the community. So I just need like a better understanding to say it's going to take all of us, despite our background of education, just to be able to support the people that we love and serve.
Yeah, I'll just add with, I want to be very clear. Victims are victims, right? Survivors are survivors. And the number one thing that hospitals and doctors can do is treat people equally, independent of why they were shot or how they were shot or how they got there or what were the actual conditions of when they got there. Because if nothing else, like that healing is important to reduce the likelihood of future violence. But too often there's a hierarchy of trauma, you know, where if someone's shot in a school shooting, it means so much more than if someone was shot, you know, in the inner city, you know, in a neighborhood that's impoverished. And I experienced that firsthand. You know, when I arrived at the hospital, before I met my doctors, I was rolled into a room and interrogated. And I went through 3 rooms of interrogation from investigators. And I was bleeding to death. I almost died. I literally almost died. And I was over here trying to explain to them that I was just walking to my car, that I didn't sell drugs, that I didn't shoot at somebody. And even if I did sell drugs, even if I did shoot at somebody, that shouldn't impact the type of care that I should receive in the hospital. So that's number one. Number two, when I was shot, my family wasn't even allowed to see me until police signed off. And the trauma that instilled in my family, my mother couldn't find me, didn't know if I was dead or alive for 12 hours. I mean, that trauma can never be reversed, right? And what happens is, unfortunately, our health system automatically yields to law enforcement, or at least that was my experience. And we have to just, one, if we really care about families, we have to make sure the health systems know that anyone that walks into your building, into your room, into your emergency room, into your care are your responsibility first. And there are real lines that need to be set between care and the efforts to solve that specific crime. Because at the end of the day, saving a life is way more important than solving a crime. And you can do both, but we should not be sacrificing lives or instilling trauma just to solve crimes. The second big thing is that a lot of our folks who are being impacted by violence, they don't know about the resources and assets that are available to them. Things like the Crime Victims Fund that can help pay for hospital bills, that can pay for therapeutic care. Unfortunately, when folks are shot, when they leave the hospital, they're only given, in most situations, their health care information. They're not given the information about what else can be done to support them in their journey as a survivor. That information is readily available. And so doctors can equip their hospitals or their staff with, hey, here are the steps to apply for the Crime Victims Fund. Here's how, you know, hey, your family, maybe a family lost someone. Here's the paperwork for how you can get that reimbursed. And at least your funeral could be paid for. So I think like really making sure that hospital systems, doctors, and health systems understand the Crime Victims Fund and are able to engage those who have been impacted will go a really, really long ways to supporting families. And the last big piece I'll just share is that, you know, when we were in the Biden administration, we clarified, not through executive action, but clarified that Medicaid can be used for violence prevention efforts and for long-term victim services. And so at this point, we could definitely use the help of the health systems and doctors to make sure that those resources and supports are being offered. And for those folks who are eligible for Medicaid, know that there's so many people, like gun violence now is the leading cause of newly disabled Americans. There should be no one that's eligible for Medicaid that's disabled from a shooting that's not leveraging Medicaid to pay for their long-term care. But they don't have that information. Our health systems understand Medicaid inside out. And so we need doctors and healthcare systems to really help connect the dots between how Medicaid can help with long-term support, long-term recovery, and even violence prevention efforts. And so those are three things I would say. Own the health system and make sure you're protecting that from being abused and manipulated by law enforcement. Two, ensuring that your victims and families understand the Crime Victims Fund and how to leverage it. And then three, really pushing and leaning in on the usage of Medicaid to help survivors of gun violence.
That was incredible advice. Thank you all. Thank you, Greg, and thank you to all of our panelists for your great answers there. My next question, going off of the amazing work that you did in the Biden administration, Greg, and with the current administration's rolling back of a lot of these initiatives, in general in this space, what motivates each of you to continue your work in the firearm violence prevention space despite experiencing setbacks or resistance from policymakers?
As humans, we don't need inspiration to breathe. And this is the number one cause of death for youth in America. Our entire future is under siege. So we should need inspiration. We need to really just, every time you see a young person, you need to be reminded that if we don't fix this problem, their life is in danger. And so for me, and maybe it's a little bit closer to me because I'm a survivor personally, but I don't need a lot of inspiration. It's more about this is a very present danger that is around every corner. And it's something that's harming people every day. It's harming people in our families, but it's a very preventable and fixable problem. And we've shown that the last 3 years in the Biden-Harris administration, we reduced homicide by 31%. We know how to fix this problem, but we have not fixed it yet. And so my inspiration lives in just seeing people around me, seeing young folks, seeing, this is the number one cause of death for Black men in America, number two cause of death for Latino men. This is the leading cause of death for pregnant women in America. So every time I see a pregnant woman, I'm like, man, I got to address the biggest threat to their life and to their family's life and that child's life. And so I see that inspiration everywhere I go. I also see the inspiration in the people who are fighting. There are thousands of organizations that are doing frontline community violence intervention work. There are dozens of organizations that are doing advocacy work. We are literally just leaving the courthouse where lawyers took on the Department of Justice and said, you will not remove these funds from our communities and from our violence prevention efforts. And they won that battle. Now, I don't know what the judge and the jury are going to decide, but anyone in that room knew that our argument was way stronger than the other side. And so I'm just inspired by everyone who's willing to fight for our futures, willing to fight for our lives, fight for our families, for our youth. But at the end of the day, this is way too urgent. I mean, this is literally the biggest health crisis of our time. And the Surgeon General acknowledged that. And so, inspiration shouldn't be hard to find. At this point, what we really need to think about is like, where are the opportunities? Opportunities are hard to find, but inspiration should be very present.
I don't know if it's much more to say after that. Greg drops the mic pretty frequently on these calls, but what I'll say from the physician standpoint, I think that, there's certainly a lot of, there are moments of discouragement in the policy space. And there's oftentimes you get told no frequently. And I think for me, in the last few years I've been involved in this space, I think what motivates me the most is thinking about those who I've cared for, the many people who I've pronounced dead or told their mothers that, their children aren't coming home, or brothers that, their brother you'll never see your brother again. I think when I feel discouraged, I think about them. I think about It's hard to remember faces because, quite frankly, we see so much death at the trauma center. So I try my best to think about those people. I try to also think about it's a privilege, right, to not um, for those who live in this reality every day, knowing that they can be a victim any moment and I can go home and I can feel safe. I don't have to worry about waking up one morning or overnight and a bullet crashing through my window. I don't have to worry about walking down the street and thinking that somebody may a stray bullet or somebody may intentionally try to harm me. And so, recognizing that that is a privilege, recognizing that I don't uh that I have the opportunity to be a voice for the voiceless, the people who are disenfranchised or don't have the opportunity to speak for themselves, I think is what really drives me. I think also, growing up, I lost friends to gun violence. I also have friends who are incarcerated because of gun violence. And so, I think I take it personally, I take that personal responsibility to fight for them, to acknowledge that, I had privileges that they didn't, that led to cycles of gun violence, and that it's up to me to try and to speak out and to use my voice and to use my credentials as a physician to raise these stories and to raise these experiences to public consciousness. So I would say that I think it's pretty easy. To Greg's point, it shouldn't, especially as physicians, as surgeons, as trauma surgeons, it's not hard to find motivation when you spend just a single night in the trauma center and you see what this problem really looks like day in and day out.
I agree with Greg and Dr. Douglas that it's the other people in this fight who also keep me going. Particularly the mothers who have lost children. There's just really nothing worse in the in the world than losing your child. And these survivors that I've met across the country, they have become like family to me. They're constantly showing up, constantly trying to make this world a better place for future generations. And I'll just say, when I worked on getting legislation passed regarding unsolved homicides, I worked with an amazing group of women here in the state of Illinois and another amazing group of women around the country. And these women are just so strong. Not a day goes by that they don't think about their kids who they lost, and not a day goes by that I'm thinking about my dad. But instead of just sitting around, they wanted to get up and actually do something. So, I mean, despite the current administration and where we are, I believe that change is possible, even if it's very slow moving, and that every conversation, just like this conversation here, it just moves us further along.
And I think to add to all of the amazing panelists, like my inspiration is that I'm a mom, and the fact that um, the privilege that Dr. Douglas or Anthony is speaking about, I think it's becoming more clear every day that that privilege is becoming less of a privilege, where like political violence is happening. When I first started this work, the mayor of my city, Mayor Frank Jackson, he had to come to a scene as his grandson was one of the victims of gun violence in our city. So I think the privilege that we once thought we had is becoming extinct, where gun violence has no borders and bullets have no names, and gun violence isn't just specific to impoverished communities, but the inability for anybody to handle conflict with the weak laws around violence in our country is putting us all at risk. And there's no longer a conversation whether um, if it's my problem, it's everybody's problem. And I think, in one hand, that's a good problem to have. Now we have more allies to say this can be my problem, and we're all paying for it, right? If one homicide costs $1 million, like whether you want to acknowledge it or address it, we're paying for it, and we need to find value in the lives of our young people and everybody. So, motherhood is definitely my reason to keep going, and praying for better laws so that we can all be here to see the impact of the work that we're talking about here on the spot.
Thank you all for sharing on that. I think it is important to realize there are very many, aspects of what keeps us going, especially in like the faces of getting told no, and sometimes getting told no over and over again, or getting things rolled back. For our next question, I'm going to try to tie it into a question we got in the chat. I wanted to ask you all kind of what effective communication can look like between a healthcare provider and somebody impacted by firearm violence. I'm going to direct this first to Alicia. That way we have some direction here. But I'm also going to ask, there was a question in the chat coming in about how a hospital could start a violence intervention program if they don't have one already. So if anybody wanted to touch on that as well in their response, that would be great.
So the question was about how healthcare providers can communicate effectively with patients in the ER. So when I was in the ER, when my dad was shot and killed, well, I'll just tell a story really quick. So I got there, I was taken in a police car over to the hospital. And this is in the city of Chicago. And when I got there, they told me he was in surgery because he had 7 bullets, 3 were in his brain and 4 were in his arm. So he was having surgery to have the bullets removed. And when I walked in, there was 2 nurses who were just the kindest people you'd ever want to like encounter in an ER. And they just put their arms around me and took me in. I saw my dad for the last time. And then when I was walking out of the where he was still alive, there was another nurse who came around the corner, and I was just standing there, and he said, "I'm sorry for your loss." And I was like, "What are you talking about? He's still alive. He's not dead." And he's like, "Oh, I thought they told you." And so that's how I found out that he died. And that was just within a few minutes of being in there when he was still alive. So sometimes communication, I think, is, maybe wait till the person knows that they have been informed that he died. And then I went right to meet with a group, some homicide detectives. But I think there's a real missed opportunity for communication between, it's the first step when someone's there. And yes, everyone's in shock. But as someone who has an unsolved murder, that's a really key part of an investigation into a homicide case is in the ER right then and there. And they can ask questions while things are still fresh in your mind and maybe take notes and things like that. And there's and to be done in a non-judgmental, empathetic, culturally sensitive manner. I know some moms who lost their kids, and the first questions they were asked was he in a gang? And just like Craig said, and who cares? Like that is someone's son, someone's father, someone's daughter. What difference does it make what they were doing? Somebody doesn't deserve to be shot and killed.
I would say to the point of like, how do you establish a hospital-based program? In Cleveland, we had this amazing program at University Hospitals called the Anti-Fragility Program. And basically, a doctor named Dr. Edward Barksdale created this program because he saw too many children being shot and killed in the city of Cleveland. And I think there's a national program that you can reach out to called the IVY, called Alliance Violence Intervention. But there's also great programs across the country, like in Newark, New Jersey, in Cleveland, Ohio, in Oakland. There's great programs. So reaching out to those hospitals to figure out like, what do you need? One of the things that you need the most is the CBI program, people that are in community. When I talked earlier about this work being complementary, is that the hospital needs community in order to do this work, to be able to reduce the chances of retaliation, to be able to connect them to the wraparound services that will help whatever normalcy looks like, whether it's surviving the loss of whoever you lost or figuring out how to survive your wound. But really looking into those programs that work and asking questions and removing the bias, like Alicia talked about, like you don't have to worry about like what happened or why it happened. It's like, how can I help you recover? How can I help you return to the community? And as people, we all have questions, but we talk about saving a life and um, allowing people to recover, ask the questions that matter and not what feeds your ego or your whatever else you're gonna flip it.
Yeah, there's this popular term right now in healthcare, especially in the trauma and emergency medicine space, about trauma-informed care. And it's a very popular term, but I think that, the stories that Alicia shared it just it calls to just the importance of why trauma-informed care is so necessary in the hospital. And I think as simple as it can be put, because there's a lot of definitions for trauma-informed care, but I think it just, to me, and how we teach it at the University of Chicago, it just means recognizing the humanity in every single individual, not some people, but everyone. It means acknowledging that their experiences to this trauma is normal, and it's a normal experience to a very abnormal condition, right? And it means doing everything not to re-traumatize people. So it means doing your due diligence to make sure that someone has communicated to the family about the situation that their family member, loved one is in. It means not making assumptions about people because the way they look or the way they were dressed or the circumstances in which they were shot. It means leaving space for people to have normal reactions to abnormal conditions, whether that's anger, whether that's sadness, whether they expected this to happen. It doesn't matter. We see the gambit of reactions when people go through this. And the most important thing as physicians to know is that there is no normal reaction to this, to people experiencing the impact of gun violence. Saying practically, it means saying sorry that this happened to them, acknowledging that this is really hard and that you're here to care for their needs. It also means shifting our thinking, right? From a lot of times in the hospital, not just from physicians, but nurses and other healthcare providers, our thought process is, what did this person do or not do to end up in their condition or situation? And our thinking needs to shift from that to what happened to you or what disposed you to being a victim of gun violence, right? Because we know that what the causes of gun violence are, and we know that no one wakes up or is born wanting to be shot. And so I think that that is so, so important, especially as for the providers on this call, is focusing on trauma-informed care, understanding what that means, and then doing your due diligence to be aware and educate yourself on the root causes of gun violence. There's recent and past histories that have led to certain communities being overburdened and overwhelmed with gun violence. And so it's our duty as physicians to understand what those root causes are, right? We can articulate what the root causes are for breast cancer or colon cancer or diabetes, but why can't we articulate the root causes of gun violence? And so I think that is a very important part of trauma-informed care, is understanding what leads to people being injured and how you can intervene in that process. So
Thank you. That was really informative for all of us here and thank you, panelists. That was really thought provoking and helpful for all of us when we're having these difficult conversations with patients and their families. To build off of that, what are some ways that physicians or healthcare workers fall short in these conversations? And what are some things that you've noticed that healthcare providers do well in these conversations?
I would say in terms of what we can do better, I think we do a poor job of avoiding re-traumatizing patients. And what I mean by that is just causing more harm in a very difficult situation, especially in the trauma bay. If if you are not a victim or haven't been in the trauma bay, the first thing that happens when victims come in is people cut their clothes off, right? It's a loud environment. People are yelling, they're screaming. Sometimes people are not communicating to the patient what is going on. Sometimes patients are left uncovered in the trauma bay, lying on their back. And so I think that it's a very scary moment. And don't get me wrong, there are times when somebody's, sick, very ill, that, some of these things are necessary. But I think that we should be more thoughtful about the process that we put people through after injury. If it's not necessary to cut their clothes off, don't cut their clothes off. Over communicate with patients. That is very important. Tell them what is going to happen. I've seen people who are not deathly sick, who come onto in our trauma bay. They lie on the stretcher, And the first thing, before anybody says anything to them, there's a large IV being placed in their arm that is extremely painful for patients. So I think it's so important to communicate what is going on with patients, with people who are coming into our trauma bay. I think oftentimes, and this has been alluded to earlier, we do a poor job, especially for our gun violence victims, of treating them as criminals, or treating them as if they were captains of their own fate, and that is why they're shot. There have been times in the trauma bay where I've heard people say, what was she doing this early to be shot? Or, look at his tattoos. He's probably affiliated with the gang. Or, why can't they just stop shooting each other? And I think we need to intervene when we hear these type of comments in our hospitals, especially as providers, and to educate when appropriate. Of course, it's difficult, and I think that this is where our hospital systems could do a much better job. We do all these trainings as physicians and healthcare providers on fire safety training, biohazard training, trainings that we never use, cultural competency training. And so why not have trauma-informed care training? I think that's very important, especially for the people who are interfacing the most with the patients, the nurses and physicians. And so I'll stop there so I'm not long-winded, and I'll let other people speak, and I can talk about what we could do better.
In my experience, once I left the hospital, first of all, I 100% agree with you, Dr. Douglas. That's first 100%. When I left the hospital and my dad was killed, I didn't have any further contact with the doctors or nurses who were there that day. So there's limited continuity of care and pretty much zero follow-up. A lot of survivors that I know had PTSD from their particular shooting, and I don't think they were ever offered any counseling to deal with any of the mental health side effects. I think there's also a failure to address broader social and community impacts that can be too narrowly focused on the individual without addressing the wider effects of firearm violence on families and communities, including secondary trauma and safety concerns. And I know also, I know this is changing quite rapidly, but my kid's pediatrician still doesn't ask me if I have a gun in our house. And it still remains the number one killer of kids and teens. And I bring it up to her at every one of our well checks, but it's quite a big missed opportunity to discuss firearm safety and safe storage with parents. I mean, they'll ask me if my kids have a helmet on when they ride their bikes, if they wear a life jacket when we're out on a boat, even if they wear sunscreen. And I'm like, are you kidding? It's still, guns are the number one killer. But I mean, yes, melanoma is important too, but I think they should, that's just a missed opportunity. You have somebody who's, captive audience. And, but I know that is changing. The other hand, I think physicians, so have I experienced a positive interaction with doctors and other healthcare workers? 100%. I think physicians and healthcare workers in general are one of the few groups who are most likely to pivot, adjust on the fly, and really work to change things for the better over all other industries. Healthcare workers are in the business of saving lives. Other industries may use the excuse of addressing gun violence as political, but I don't find that healthcare workers do. Instead, they put their heads down and they come up with solutions that are meaningful and achievable, and that's very commendable.
I know that Greg has been on here, but when he was the deputy director at the White House Office of Gun Violence Prevention, he created space for white folks to come to the office and talk about the trauma that they experience as serving patients in communities that are impacted by gun violence. So shout out to Greg. I think another thing that some of the challenges is that based on healthcare comfortability with the patient, like how they respond is how they treat them. So if you come in there hostile, their fear will allow them to treat them in a way that makes them feel empowered. And I was able to see that firsthand. But if you have a patient or a family that is less hostile than you see, it's been shown that they treat them better because they don't have that fear of being hurt or harmed. Alicia, to your point, in the city of Cleveland, the Academy of Medicine offers gun locks and storage boxes, and the doctors have to ask everybody if they need one, and not asking in a way that says, like, do you have a gun? If so, here you go. But it's just like, we have gun lots and storage boxes. Would you like one? Because the mistrust is like, if I tell you I have a gun, then maybe you'll report that to someone. So we worked on language so that they can just offer it. And if it's not for you, do you know someone who may have a firearm that needs storage? Kind of like the COVID route. It's like, we're not looking at an individual base, but assuming that everybody has a firearm, and here's something that you can use. And I know that University Hospital and Metro Health Hospital are both utilizing gun lots and storage boxes in their trauma department and offering them to people who are victims of violence.
I think Maisha and Alicia's points bring up why it's so important, especially as physicians, for you all to get involved in your associations, whether that's whatever academy or association is relevant to your specialty, because these associations often are making decisions about what policies they're going to support and what their agenda is going to be. And I know Dr. Akbarni is on the call. I'm not going to air out her drama, but there has been efforts to include gun screening in the pediatric evaluation and the well child visit in our state of Illinois, and it has been opposed by some associations for pediatric care. And I won't name names, but I think that's why it's so important for us to be involved in these associations and provide leadership in these organizations, so that you guys can be the difference maker for these organizations. And then the last thing I'll say is, I think in the long term, right now we're doing an excellent job at addressing patients' physical needs. The advances in healthcare and in trauma care, we're well equipped to address those type of needs after being shot, but we're failing at addressing the psychosocial needs of patients. And I saw there was a question about what primary care providers can do for patients who have been victims of gun violence. And I would say, I think that we need a better assessment of patients' psychosocial needs after injury. What is their access to healthy food? What is their housing situation? Do they have access to stable and secure housing? Are they employed? Do they have health insurance? Do they have access to mental health care after injury? And I know that's a lot, asking a lot of our primary care physicians, and the burden is not all on them. But I think that after injury, it is so important that we are assessing what their psychosocial needs are after injury, especially to prevent people from coming back. I can't tell you how many people in our hospital we take an X-ray of after they've been shot and find out that they already had a retained bullet. And that is a miss. That means that we failed that person when they discharged from the hospital in addressing their needs to prevent them from being a victim again. And so I think that is so important right now. And honestly, our hospital-based violence prevention programs do as the best job that they can, but they're not equipped with the resources to address all of these psychosocial needs after discharge. So we need to do better in that space.
Yeah, those were incredible answers by all of our panelists. I think just highlighting, the research shows that we're just not asking these questions. We're not asking about firearms with patients. We're not getting the training to do so. And it's an uncomfortable conversation, but it has to start somewhere. And it's that peer-to-peer training amongst us as healthcare professionals to teach each other how to have these conversations and also learn from experience. I think, using neutral language, like Maisha and Alicia said, where if we ask, like, are you around guns? Are there guns near you? Instead of maybe a patient putting up their guard up, then we can provide them the resources they need. Building that trust is so key. And to your point, Dr. Douglas, that long-term care is so important. It doesn't just stop at the emergency room when they get care and stabilization for their injuries. The injuries and impacts go long after that injury and impacts in the community. And it takes all of us in a coordinated effort, all these resources together to help a patient. But I see Greg has his hand up, so I'll let him
Yeah,
jump in.
I was gonna say something really quickly. You can bill Medicaid for this. There's a financial incentive. And I think we need to make sure we're pushing our health systems to take advantage of that. That that is an acceptable use of Medicaid. And so every conversation you have with the patient is eligible for Medicaid, that can be billed. And so like we're not being trained. It's not socialized across all states. But there is a financial incentive, and I think it's important for you all to know this, and hopefully like push on your health systems to step up and prioritize this, even if it's just for financial gain. We know it will save a lot of lives when it comes down to what it means for our communities.
Yeah, and thank you, Greg, for rejoining. Great to have your input on these questions as they come in. I just quickly want to touch on something Maisha mentioned about the event at the White House last year that Greg helped put on, the White Coats at the White House. With DFA, we were really proud to help put that event on. Many of our members attended, and it was just a great way to kind of kick off a conversation or continue a conversation that had been ongoing of, how can we in healthcare really, better the communication we have with patients and survivors. As I mentioned at the start, I'm a fourth year medical student, so I'm still very early in my medical career here. And medical school, we get lectures on microbiology, pharmacology, and risk factors for diabetes and heart disease, but I didn't have a single lecture that addressed gun violence, which, as has been mentioned, is the number one killer of kids and teens. And huge rates of disability for people in America. So just at the training level, we're just not getting that foundation. So I think, speaking as a medical student, groups like DFA, being involved in state societies, medical societies, even just as a medical student, if there's any medical students watching this or tuning in, like there are ways that you can get involved too, in addition to kind of what our panelists have said here today. You can write resolutions, ask for this to be included in medical education. So I just wanted to add that as my 2 cents here. I think we have time hopefully for one more question, and then if there are any remaining questions in the chat. But kind of continuing it, what are some ways that you all think that people in the community, regardless of if, they're a healthcare worker, if they're not a healthcare worker, if they are currently involved in healthcare advocacy, how can people get involved and advocate for meaningful change in regards to firearm safety? And whoever wants to take this one to start, feel free.
I could jump in. Danny, you laid it out perfectly. The beginning of the advocacy starts with the folks that are right around you. And the fact that this is not being taught or discussed in our medical schools is really terrifying. Because when we think about the violence and just the sheer number of people who are being harmed by this crisis, we need to start there. I think your advocacy can start right in your medical school. Like, we may not have to talk about the political angles and the policy angles of gun violence, but we should at least be talking about the surgeries, the response time, the recovery, the long-term care, the short-term care, the victim services, the impact of trauma. So I think that's a huge place to start. Secondly, there's really two sides to this fight. There's the resources and there's the regulation. And on the resource side, we can start at any level. You can start at the city council. If you're in a rural community, you can push at the county level. But the first place to start is how do we make sure we have enough resources for victims and families that have been impacted? And nearly every community is underfunding those resources. So starting there is important. Secondly, how do we invest in violence prevention efforts in inner city areas where homicide is a big challenge? That's CVI. In urban areas, it's mental health resources and frankly, veterans resources and those who have been impacted by other forms of trauma. But investing in violence prevention is a huge, huge priority that we can fight for at every single level of government. But then when you think about states and federal, that's where we can really start to push on the policy and regulations. And just to keep it very simple, the best way to think about this is we have to focus on upstream accountability. For too long, we have prioritized harsher incarceration and longer sentencing for a 15-year-old that has a gun. But we haven't actually put enough energy into gun dealers, manufacturers, gun traffickers, gun sellers, those who have been, excuse me, keep going straight. Sorry, I'm in an Uber. We doing this live. But we have not focused enough on upstream accountability on the folks who are profiting off of this huge crisis. And so holding the gun industry accountable from gun stores all the way up to manufacturers and investors is really where we need way more policy to be pushed and advocated for. And if you want to have an example of what can be done at your state level, when we were at the White House and it's still live, we created what's called the Safer States Agenda, which lays out 15 policies that every state can implement to help reduce violence. And frankly, every single state has some work to do. And so I would encourage you to start there. So thank you.
So speaking of accountability, I just want to add that until we have complete accountability across the entirety of a gun's life cycle, that I don't think we're going to see a dent in ending this epidemic. We talk a lot about safe storage and on one end of the gun's life cycle, but we don't talk about accountability on the other end of a gun's life cycle, which is holding law enforcement accountable for solving murders. We leave 82% of shooters on the street on average every single year, and compounding that's thousands and thousands of shooters who just know that they can get away with it. But in terms of getting involved, I think we need more cultural change in our society, and that starts with the people who are immediately around you. There's no one size fits all solution to gun violence prevention, and how you would address suicide, homicide, school shootings, domestic violence, situational violence are all very different root causes. But the common denominator in all of those is the guns. And we need to get more information out there so that people understand that they're far less safe with a gun in a home than without one. And obviously we all know that, but I don't think the general public actually has an awareness of that.
I'll just make a quick shameless plug. I put a link in the chat, but Greg mentioned about holding those who profit accountable. And here in the state of Illinois, we're currently working on some legislation to do just that. We're working on a bill called the Responsibility in Firearms Legislation Act, which requires manufacturers to pay into a fund according to how frequently their products are recovered in injuries or deaths. And those funds go towards CVI victims of firearm injury and their families. And so if you're interested, or whether you're not in Illinois and you want to learn more about the legislation, how you can introduce it in your state, feel free to email me. I'll put my information in the chat.
Thank you, Dr. Douglas, for that. And thank you to all our panelists. I think we're kind of coming to the end of time here. So I'm going to wrap up a little bit. I think we've had a really great discussion on a lot of different points around this issue. I think the more that we have these conversations, the better off we all are, and the better off our patients and our communities are. If we're not finding that training or the education in our medical schools or our residency programs, it's kind of up to us to encourage this, and kind of work with each other to build in that programming. I hosted a workshop this past year of my medical school, so something that we all can kind of work together on, and it's a coordinated effort. And there's just to plug all the helpful links and resources that have been put in the chat for those that haven't seen that. But we'll like to close this session tonight by thanking our speakers for such a thought-provoking discussion. We are so grateful that you're all able to join us tonight. Before you leave, here are a couple quick reminders. Education is important, and so is action. After tonight's session, please take the following actions. Our Gun Violence Prevention Subcommittee has launched a form that is currently collecting both written and video submissions with the prompt, "What I wish my doctor knew about surviving firearm violence." The link will be in the chat. Please consider filling that out or providing any patient stories or sharing it to your networks. We really appreciate that as we work on what we can do better as healthcare professionals in this space. Also, consider writing an op-ed or letter to the editor to your local paper, and share what you learned with friends and colleagues. Like I said, it's up to us to kind of reach out to each other and educate one another, and with the mindset of giving better care to our patients and for saving lives. And then invite others to join DFA's work. We kind of plugged a lot of our DFA stuff in the chat, but please, if you're interested, join one of our subcommittee meetings on gun violence prevention. Come with some ideas, and we'd love to help support them and what we can do as a collective. Or if there's other areas, impact areas in DFA that you're interested, we'd love to have you there as well. We're all in this together. Please watch for additional opportunities to provide input on future policy issues. And for those of you who are paid sustaining members of DFA, just a reminder to complete the survey for 1 credit of CME for attending tonight's session. Thank you.
That link for CME is in the chat now. If you guys enjoyed this Advocacy Grand Round session, please consider supporting DFA's work and impact with a financial gift. The link to donate will be in the chat. Additionally, keep an eye out for info regarding next month's Advocacy Grand Round session on reproductive rights, hosted by our amazing Health, Justice, and Equity Impact area. Once again, thank you all for being here and all that you do on behalf of our patients. We hope you will consider being an official DFA member today if you aren't already, and take a look at the benefits of being a member. The number one reason doctors, medical students, and health advocates join DFA is to be with like-minded people. So here we all are tonight. Please remember to follow us on X, Blue Sky, Instagram, LinkedIn, and Facebook to stay up to date with all of DFA info and events, and also as a way to stay engaged. And once again, thank you so much to all of our attendees, to our amazing panelists, and to anybody watching this session at a later time. I hope you guys have a great rest of your evening. Thank you.